So let's go now to the first of our sessions. And what I should tell you is that you'll find a whole mix today. We're going to have keynotes. We're going to have some wonderful lightning talks from those people that are, really developing their careers in this institute. And we're also going to have a focus on some very specific problems. And something that is really in the news and has been a real concern of late is harm. And how do you get together after harm and sort things out? And so the person that we have to lead the session on this is Justin Waring. Now, some of you will know him as Professor of Medical Sociology and Healthcare Organisation at Birmingham, but he's also an Improvement Science Fellow and seconded to this institute. So, Justin, over to you.
Thank you for that great introduction, and good morning and hello everybody. So yes, my name's Justin, and it's a great pleasure to be introducing and facilitating our first session today on after harm. I've spent most of my career looking at the procedures and systems that have been introduced to tackle the problems of patient safety, to promote learning and to give patients and communities a greater sense of confidence in our care systems. But after 20 years, I'm not sure we've made as much progress as we had hoped for. Our desire for better learning, culture change and zero harm seems just as elusive as it always has been. When safety events happen, people, and here I include professionals and carers as well as patients, often feel vulnerable and confused and anxious and traumatised. And the approaches and methods we have used to respond to safety events can often compound these feelings. And so maybe we need to start thinking differently about how we respond to safety and safety events. And so it's important that we contribute to a new conversation about how we can deal differently with harms with compassion and dignity. I'm not going to say much more because our speakers and our panel are really the experts here. And so without delaying proceedings any further, I would like to introduce them. Our speakers, and we'll see some pre-recorded talks from those very shortly, are starting with Jo Wailing, who's joining us all the way from New Zealand, where I believe it's past her bedtime. Jo is a registered nurse and senior research fellow at the Victoria University of Wellington, and she's a leading expert in restorative practices and their application to healthcare. Next, we have Jane O'Hara, who is Professor of Healthcare Quality and Safety at the University of Leeds and Deputy Director of the Yorkshire Quality and Safety Research Group. And we'll hear about Jane's work involving patients and families in how we deal with safety events and trying to develop a restorative learning approach. And then after we hear from their talks, we'll move into a panel discussion, and Jo and Jane will be joined by Joanne Hughes, who has campaigned for a change in how we deal with the human consequences of harm and is passionate about using restorative approaches. And finally, Shaun Lintern, who is the health editor at the Sunday Times and for over a decade has brought to public attention some of the worst scandals in NHS care and helped shape public dialogue and thinking around questions of quality and safety. So now I'll hand over and we'll hear from our first recording from Jo Wailing. Thank you.
Kia ora. I'm going to talk a little bit about what happens after harm. We're going to explore why healing, learning and improvement are all equally important in the aftermath. And then we'll explore why we need to shift from an adversarial to a restorative system, what restorative means, and the evidence for restorative responses. So as you know, healthcare harm is rarely the result of a single identifiable cause or individual act. There's usually lots of complex interdependent factors that contribute to the harm. And today I'm going to focus on harm from adverse events whilst recognising these connections. So I think that there's a point of equilibrium, a state of harmony, if you like, between safety and harm that can be found by looking at health systems through a restorative lens. And in its balanced shape, that's what the collar represents here in this picture. So harm isn't an incident with a beginning and an end point, like an investigation. It's an experience that's incorporated into the ongoing relationships we have within ourselves, with other people, and within the context in which it occurs. And that can be the context of the actual health provider or the individual context that we have as people or within our families and communities. So how we experience harm and how it's responded to is going to influence how we think about safety in the future. So taking all of that into account, we define harm as a physical, psychological, social or spiritual injury or experience that occurs as a result of providing or receiving healthcare. And we include spiritual harm to recognise a specific element here in New Zealand experienced by our Indigenous peoples. So understanding that harm affects the people who both provide and receive care allows us to co-design a response that appreciates the human and relational impacts. But before we talk about restorative responses, let's first explore the impacts of current embedded responses. So in most countries, the systems that respond to harm tend to promote investigative, legal or safety frameworks that are interdependent but work as isolated investigations. So while they've got different practices and goals, they're both usually underpinned by adversarial principles. And in countries like yours and mine, healthcare harm is also in the political domain, which can increase complexity and further promote adversarialism. And I think that's perhaps why, whilst investigations or inquiries are well-intentioned, they don't reliably produce justice for the people involved. So when we think about investigations, they're usually designed within a predetermined framework. They gather evidence from documents, interviews and expert opinions to determine what happened and why and how. And these are the questions that we ask in an adversarial system. And we also assume within this lens, this way of looking at a harmful event, that deterrence can mitigate the harm, and deterrence can include a penalty or a punishment for not following the rules or other more sophisticated mitigation strategies. And these types of systems aim to rehabilitate the wrongdoer so they can get along and conform with an expected behaviour or policy. For example, with an educational intervention. And the recommendations that they lead to are very much influenced by the investigator perspective. And that's quite important because after harm, after an adverse event, there can often be an actual or perceived conflict of interest, especially when an investigation is led by people who have responsibilities for the conditions that led to the harm or the actions for repair. And those responsible parties can include professions or organisations, but also governments. So quite often, even the narratives about who's affected can pitch a patient or their immediate family member and healthcare professionals or providers against each other. And that discourse aligns with these traditional notions of justice, where there's a victim of harm and someone or an organisation who's caused the harm. And whilst there have been attempts to recognise the impacts on clinicians and organisations by using terms like second victim or third victim, that also unintentionally creates a hierarchy of victimhood and a competing sense as well between all the people that are involved. So where do we end up? Well, the principles and practices of the adversarial system, they can create these conditions that can make things worse. They can compound the harm for the people involved because they interfere with normal human or relational processes. For example, after the death of a child, the normal grief processes are affected by these multiple protracted kind of investigation frameworks, coronial processes, safety investigations, legal frameworks. And they also erode people's dignity when they don't include the people in the most directly impacted by the harm in the processes. And this can also contribute to epistemic injustice when we unfairly discriminate against people in their capacity as a knower based on prejudice about the speaker, such as their gender or social background, or these hierarchies that we have. And harm consumers often talk about epistemic injustice, as do mental health clients as well. And when we fail to create a safe space where people can provide an honest account because we keep people apart in the adversarial system, we actually prevent the conversations that are necessary for healing and learning and for that restoration of trust in relationships between people. And when we fail to appreciate and respond to the justice needs, either by not listening for them or by prioritising the needs of the system, so that would be usually learning and improving over healing, or the needs of the people involved, which can be quite diverse and can often be easy to address, we can also compound the harm. And the issue with this is that when harm is compounded, we actually create new harms and new ripple effects. And there's a growing body of evidence that the way that we currently respond can create these conditions for PTSD and anxiety and depression, suicidal ideation, and intergenerational trauma. And when compounded harm remains unaddressed, it can grow and spread and intensify, and people will actually seek voice and agency through other means, such as activism or the press or lawyers, and things can take on a life of their own. And you can see that playing out at the moment in the maternity scandals across the NHS. So what do people actually want? Well, they want a response that's underpinned by the espoused values and beliefs of healthcare institutions all over the world, including the NHS. So care, compassion, healing. They want a healthcare response, but they also want a response that upholds their dignity, where they're seen and heard and listened to and treated fairly, and where people are recognised and understood and feel safe in the world. And people also want justice. And this is where it gets a bit tricky, because justice is something that we talk about all the time without being really specific about what we mean. Whilst it's one of the most important moral and political ideals that lies at the heart of what societies regard to be right and fair, based on the moral concepts of ethics and rationality and law and religion and equity, how you as an individual conceptualize justice will influence how you understand it within the health system context. And it will, your own personal and professional ethics and beliefs will actually influence what you think is just when an adverse event occurs. So it's not just as simple as saying, you know, we're going to create a just process using an algorithm or a framework or a process, because it's actually quite a subjective experience. So what we tend to focus on in restorative lens and what we need is a harm response that is human-centered, can mitigate the risk of the compounded harm I talked about earlier, but one that can also address, triage and respond to the emergent justice needs of the people who are directly involved as they change through the life course of a review or an investigation, or their experience of the harm. And this is where restorative really does come to the fore. But what exactly is it? Well, restorative philosophy considers the world through a relational lens, and it's got roots in Indigenous cultures and also in Western science. Restorative principles are relational principles that are concerned with upholding human dignity within human relationships. And restorative practices operationalize these principles in language, in conversations, in facilitated meetings, and also in circle processes. So restorative principles for me, as a clinician, are synonymous with my understanding of how a healthcare system should operate. They're about voluntariness, informed choice, being truthful, equity and safety, taking responsibility for our actions, treating people with respect and compassion and validating their experiences, and ensuring that people can make dignity-enhancing decisions. When we think about these, you've probably heard these three terms to describe restorative work, and all three are concerned with development of knowledge about how open, trusting, and respectful relationships create safety, promote well-being, and prevent, mitigate, or respond to harm. And restorative justice tends to refer to reactive processes, and that's quite widely applied, for example, in justice systems or legal systems rather. Restorative practice can be both proactive and reactive practices that operationalize relational principles, and that's used quite widely in education and organizations. And restorative just culture is a more recent term that's emerged from Sidney Decker's work, which focused on the harm experience of healthcare workers. So how do we operationalise these principles in the systems that respond to harm? Well, I'm sure you've already got by now that we need to take a human-centred and relational lens. So we understand that health systems' resource and source of resilience is the people, their relationships to each other and the whole. We understand that and prioritise, nurture and express these principles in policy and practice and in our work. We consider the needs and the voice of all people affected by system function equally, regardless of their role or the status. And we appreciate that these dynamic and uncertain contexts influence safety and people's ability to respond to and recover from harm. So we understand that safety is created from our human capacity for learning and growth and development through this connection and collaboration, and that humans are more likely to make positive behaviour change when those in formal positions of authority work with them rather than doing things to them. So we embrace this idea of mahi-tahi, of co-production and co-design, where we work together, but we're also sharing power and risk and opportunity, both when all is well and when things go wrong. And when things go wrong, a restorative response is focused on restoring wellbeing, relationships and trust as far as possible, alongside learning and improvement. And you can see that we ask quite different questions. And these 4 questions underpin the 4 phases of a restorative response, which is very much focused on who's been hurt, what they need, who's responsible for meeting those needs, and then how we can repair the harm and make relationships right again before we think about prevention. We do that through these phases. The process itself, the response, is co-designed, guided by a skilled facilitator who's invested in all the people who are involved, and prepares and supports people in ways that matter to them. And if it's safe to do so, we bring people together to listen and to understand to the impacts and to identify the justice needs of the people involved. And then we plan and act, and that means taking responsibility for the harm. And that requires those who possess an organisation authority or have a professional moral obligation to those affected by events to respond to a situation in a way that addresses the needs and the rights of everybody involved. And then the final phase is reporting and evaluating on these processes. So ensuring that the actions that have been agreed to are not only co-designed and negotiated openly, but there's also real transparency around what is possible, and there's a clear plan for implementation, governance and follow-up. So does it work? Well, this is the same framework we applied in our national inquiry, a restorative response to surgical mesh harm, which produced similar recommendations for learning and improvement as traditional inquiries that we used in the UK and Australia. But our evaluation concluded that hearing people's accounts firsthand and involving the community required to act for repair is more likely to motivate people to collaborate and deliver change. And we also found that restorative responses have the potential to meet psychological and procedural needs in ways that current responses do not for all involved. So because we found that healing after harm is possible within a relational framework and should be embedded alongside existing regulatory structures, policies and procedures, we've actually formed the national collaborative that was established with those ambitions in mind. Our members include regulators, agencies, consumers, clinicians, Indigenous leaders and health and safety and human resources practitioners who are influencing policy and practice within their own spheres and communities and organisations. And our recent successes include the inclusion of restorative principles in national policy, in job descriptions, and investment in capability building, with students self-organising into these networks that are growing restorative. And if you think that it's expensive, then please know that Merseycare actually found that there were considerable economic benefits when using restorative to respond, particularly in the HR space. And they saved approximately 1% of their total costs, 2% of labour costs. And I think that's quite significant So I'm just going to leave you with this thought. There's a lot to do. And my challenge to you today is to critically evaluate the impacts of your responses in your own context and ask yourself if they're human-centered and are equally focused on healing, learning and improvement after harm. Thank you.
Well, good morning. What I'd like to do in my presentation is build on what Jo has discussed and to explore how we have tried to build in some restorative principles into the way in which patients and families are involved in serious incident investigations. I will explore how within the NHS we might start to operationalise what feels like an intuitively attractive idea and really explore if we can move this from rhetoric to reality. So first, what I want to do is to give you a brief explanation of what we have done to try and involve patients and families better in serious incident investigations. And when we started developing this research in 2018, we had a relatively simple set of ideas, I guess, that was based on our research work to date. We knew that investigations were officially designed to help organisations learn, but also that generally patients and families were not routinely involved in them. So we knew that we were really missing a key perspective in investigations, and we wanted to explore if we could improve learning by involving patients and families more effectively and systematically. And so we were then lucky enough to be able to be awarded a substantial grant by the National Institute of Health and Care Research to develop and test new processes and guidance to support better patient and family involvement in serious incident investigation. And in this work, we have partnered with 4 regional NHS trusts and the Healthcare Safety Investigation Branch. But before we could develop anything new, we really needed to understand how organisations undertake and how people experience serious incident investigations. And to do this, the first thing we did was to look at over 40 incident investigation policies from across the NHS in England. And we also reviewed the scientific literature on people's experiences of serious incident investigations. And most importantly, we then also spoke to over 50 people from across 3 key groups about their experiences of serious incidents and investigations. And those groups were first patients, families and their carers. The second was healthcare staff who had been involved in an incident, in a serious incident investigation. And lastly, and quite importantly, investigators of serious incidents within healthcare trusts, but also within the HSIB. Now, sadly, I don't have time really today to go into all the amazing insights that we have gained from this phase of work, but I do want to highlight one key finding. Now, as we expected, patients and families, of course, did want learning to be a key outcome of investigations. But we also found that they had a range of needs that arise not only from the original index incident, but also as a result of the investigation and the conduct of that investigation itself. And so we found that far from being just an objective process to determine facts, investigations were relational and they were very complex. And so our challenge became, can we develop processes that support both learning but also aspects of restoration for those people involved? And we call this potential approach restorative learning. So what do we mean by restorative learning? Well, our current conceptualization is this, that it's an approach that doesn't just focus on the need for organizational learning, but rather one that also tries to support healing and the restoration of trust for key people involved. So how did we proceed to develop the new guidance and the new processes? Well, first, we had to draw this emergent evidence together and craft some core foundational principles for how a restorative learning approach might work. Now, I haven't got time to describe these, but if you are interested, they are on the website that I will signpost to you in a moment. Now, as you can see, they range from things that you might expect, like making apologies meaningful, but they also involve things that perhaps might be more challenging for certain parts of the world of safety science. An example of this is the need to accept the inherent subjectivity of investigation processes. And this last one is really important if we are trying to support more relational and restorative approaches to investigations. Now, these principles formed the basis of our co-design of the new guidance to support better involvement of patients and families. So what we did was we brought together a co-design community of over 50 patients and families, healthcare staff, managers and policymakers. And through an intensive 8-month period, we developed these new guidance documents and a training package, with also plans to explore what types of support patients and families might need during investigations. Now, this guidance is designed to work together. So the investigator guidance supports them to more systematically involve patients and families, but we've also developed then tailored guidance specifically for patients and families that mirrors the process from their perspective and supports them to actively engage in the processes. And finally, alongside this, we also developed a short online training program for investigators to support them in using this new approach. And if you're interested in any of that, all of the documents can be accessed and downloaded from our website using this QR code, or indeed the website that's listed there. And we've been lucky enough to be invited to help develop the new guidance for engagement of patients and families that forms one of the 4 key components of the new patient safety incident response framework. And if you go and have a look at that document, you can also access these documents through there. So at this point, it's important to be clear specifically how we have tried to integrate restorative approaches into our new approach. So like anything in healthcare, we felt it was wise to start from where we were, and we tried to build restorative approaches into existing policy-driven processes rather than reimagining them entirely. And we're also acutely aware of the incoming policy change of the new patient safety incident response framework, and really the need to develop an approach that fitted within that. So as such, we've arguably taken only baby steps, perhaps, towards a restorative learning approach. The first way in which we've tried to integrate restorative principles is that our new approach is specifically designed to acknowledge and reduce compounded harm resulting from poor experiences of investigations. The second thing is that our new approach explicitly asks investigators to discuss what patients, their families and carers need following the incident and throughout the investigation, and to try to get them to signpost patients and families to relevant support. And the final way that we've tried to integrate a restorative approach is that our materials and the training explicitly highlight and try to give both time and credence to the more relational aspects of investigations. So hopefully by now you understand a little bit more about the programme and how we have tried to integrate restorative principles into our new approach to involvement. But what happens when you try to enact these principles in practice? What happens, if you like, when the rubber meets the road? So following the co-design, we have started to test our new approach across our 4 partner NHS trusts and the HSIB. And we are following 25 investigations in real time to understand what happens when we systematically involve patients and families more. But before I talk about some of the specific issues, I want to get you to think about something first. So let's think about what the key perspectives are that we need to accommodate in an investigation. And in my mind, there are 3 key perspectives. First, of course, we have patients and families. And if we combine the 2 elements of a restorative learning approach, we recognise that they will want to learn about what happened, but also they may have other needs that arise. And they may be specific physical or psychological needs, but also needs relating to the conduct of the investigation itself. And then next we have healthcare staff, and they too will want to understand what happened, but they also might have certain needs for themselves that I believe should be also supported in a restorative way. And then finally, we have the organisational perspective. Now, they will always say that learning is their top priority, but even the organisation may have other needs too. So some of these might, for example, be supporting their staff or indeed reducing reputational damage. Now, you might hope that there's or expect that there's a sort of sweet spot in the middle here, that we could bring all of these key perspectives together. But what we have come to understand is that on certain aspects of responding to incidents, that there may always be some divergence. And we think it is this divergence that can lead to compounded harm. So to illustrate that, let me give you two examples that have directly come from evidence from across our programme. Let's consider first the seemingly straightforward question about what an incident is and what should be investigated formally. Now, organisations might want to focus most of their energy on investigations that have the potential to provide the most organisational learning. But from the patient and family perspective, perhaps they're more likely to want an investigation specifically to provide answers about their particular experience that might help them make sense of what happened. So in this example, there is an immediate divergence between two perspectives that you might think on all other aspects might be morally signed up to the compassionate engagement of patients and families. And you might ask, why does this matter? Well, it matters because this foundational decision can lead to all kinds of distress for patients and families. It can erode their trust in the system, and it can lead, in some cases, to an exhausting and extended battle to get heard and to have their case examined. And this first example is particularly relevant given the power that the PSERF gives to organisations in terms of how to respond to patient safety incidents. And it is a perfect example of how a seemingly logical decision based on organisational priorities can lead to an experience for patients and families that goes against all that the organisation might otherwise hope to promote. And my second example is about what a good investigation looks like and comes directly from our experience working within the current testing phase with organisations. Now, from an organisational perspective, they might view a successful investigation as one that is within a defined timescale, that identifies relevant learning and implementable actions. On the other hand, these things might be far less important for patients and families. Now, of course, they're going to want investigators to proceed as objectively as possible and explore what happened in detail. But what we are also finding is that what matters perhaps even more is that investigations can be flexible to accommodate the questions of patients and families where possible, within timescales that suit their lives and their circumstances, and where the investigator truly engages with their feedback and really tries to make changes to any final report on the back of that feedback. And again, it is important to articulate what happens when this divergence of priorities occurs. And in this example, we find that investigators are forced into really being the sort of malleable buffer between the rigidity of organisational procedures and trying to accommodate what the patient or family needs. Now, some of our investigators have found this really difficult, particularly when they're trying hard to provide compassionate engagement and truly want to be responsive to feedback from patients and families about the report. And in terms of patients and families, no matter what their experience is of the process of engagement, if they have felt like the organisation is only really paying lip service to transparency or the process of engagement, this actually might feel even worse than if the organisation had not attempted to undertake compassionate engagement at all in the first place. So what we see from these examples is, yes, the usual critique about organisations being overly focused on reputational damage or being obsessed with outcome over process. And indeed, this is true. But what we also see is that the path to compounded harm may well be paved with good intentions. Individual investigators cannot act alone to achieve a more restorative approach to investigation. So before moving full throttle towards restorative approaches, we do need to pay attention to and to put in place a foundational infrastructure within which these new ways of responding to harm will work. So to conclude then, in terms of restorative responses to patient safety incidents, can we move from rhetoric to reality? Well, yes, I think we can, and indeed we should. But, and this is an important but, we cannot proceed without dealing with a few key issues across national and local policy and infrastructure first. So first, what we need to remember and really sign up to is that the learning should really only be one outcome of interest to organisations. Second, organisations need not to assume in their policies that everyone wants or needs the same thing, or indeed that it is easy to reconcile these different perspectives, because it isn't. Third, organisations really, really need to resource this work properly and to train people properly. And this is because, fourth, the relational work of investigations is work, and it needs to be recognised as an essential and important part of the process. And finally, organisations do need to look at how these more compassionate, restorative approaches actually fit within their current systems and processes and identify points of divergence. I don't think we'll always be able to reconcile all of these divergences, but at least we can be prepared for them so that in responding to incidents, we can try to tread the path of least compounded harm for the most people. And before closing, I would just like to say a huge thank you to all who have contributed to or who continue to contribute to the Learn Together programme. Thank you.
So thank you to Jo and Jane for their fantastic talks, and I'm sure you all found that really fascinating and stimulating. What we'd like to do now is facilitate a discussion, both with our panellists who are all here, but also with you out there. And please use the chat function to raise any thoughts or any questions. We will then try our very best to incorporate those into our ongoing discussion for the next 30 minutes. What I would like to do, first of all, is really to invite our two panellists, so Joanne Hughes and Shaun Lintern, to reflect upon what they'd heard and from their different perspectives to think about how a restorative approach can help contribute to and advance our thinking around patient safety. So I'm going to turn first to Joanne and invite her to say a few words. Thank you.
Thanks, Justin. Yeah, so just as a little bit of background about me, I lost my daughter back in 2011, and I've spent the last 11 years really trying to make sense of what is the experience for people who are affected by healthcare harm. How do they understand their needs and articulate those in that very disorienting phase when it's just happened, rather than getting sucked into processes or receiving advice from voices that put them sort of in these adversarial spaces and create so much more compounded harm. And that's where my interest in restorative and relational approaches, principles has flourished from. Listening to the tutors, I think my observation, reflecting on the needs that I had and the needs that I think people in this position have, is that there's two things going on. When Jo Wailing really clearly talked about how for patients and families, what we want is to be recognised as people who have been harmed, who have harms and impacts upon us from which we want to heal. And our expectation of the healthcare organisation where this has happened is to recognise us as people to be cared for, and to provide that care that we need by leaning in to understand how has this harmed us, what are all the harms, what are all the impacts, the needs that have been created by this event for us, and what responsibilities does the organisation have around healing those. And I think that the organisational restorative responsibility to assist our healing is this global thing that we're crying out for. And then there's a learning response, which is really one small part of getting at what we need for our well-being, our trust and our relationships and our healing, which is our understanding of the event. But the learning response, the PSERF, I think we should be very clear that the questions that is designed to answer is what was the event, what were the incidents, and how did those incidents come to happen. But it's not looking at how did that incident harm you, what has that incident meant for you, what impact has it had for you, and what responsibilities do we have in responding to those impacts? One, what responsibilities do we have in acknowledging the harm that this incident has created for you and take responsibility for your harm? And two, what responsibilities do we have to respond to that harm with a duty of care to help you heal and to not create any further distress for you? So I think they're two separate things, and I think it's absolutely right and brilliant. We're looking at the learning review process and ultimately what we can do to avoid that process creating any compounded harm for people. But we need to be clear that not to confuse the learning review process as the organisational response, because I think that's really dangerous.
Thank you, Joanne. That's brilliant. Shaun, could I invite you to offer your reflections now, please?
Yeah, good morning, everybody. So I think I found the two presentations really encouraging to me to hear Jane's work, and that this is actually being sort of looked at and actively pursued. But I think where I come from on this, naturally, given my role, is I very much approach this in my experience. I end up coming into this at the worst end of the spectrum, really. And in my work, I meet patients all the time, and one of the phrases that I hear so often from almost every family that I deal with in my work as a journalist is I'm speaking to you because I don't want this to happen to someone else. And whenever I hear that, I feel a terrible sadness, because unfortunately I know that mission won't be met and that it will happen to someone else. And that's, in the decade I've been covering, 12 years now, covering health and safety, particularly, that seeing repeated things. Maternity is the obvious example, where we keep seeing scandals emerging all over the country, often involving the same things. So I think we're just not learning. And what I see is a system that breaks people. And it was interesting, Joe talked about compounding harm. And I see that all the time. And it's one of the drivers of why patients and families contact people like me, because trust has been broken. They have a lack of confidence that anyone will learn from what's happened. And sometimes they fear something more sinister is going on, that there's an active attempt to a cover up. And, we do find examples of that, sadly. So I think there's a lot of, that's all very negative. Naturally, I'm a journalist, so I suppose I come from that perspective. But I think for me, what it was interesting listening to both Joe and Jane, that, when staff are given rules and shown the way forward, it can work. And I have seen examples where trusts have done the right thing. And often for me, what I've noticed is that's a leadership choice. There are certain chief executives or medical directors who will take an issue by the horn, so to speak, and really grapple with it, and they will give the staff beneath them the permission to be more restorative with this, to be more accommodating to the family's needs. And I think it's where we see leaders giving permission to staff and breaking through the rigid barriers that Jane talked about, and we see that all the time. So I think where we do see it working, it's few and far between, but it's often and I think my reflection this morning is that whilst some great work is being done, Jane's work sounds fantastic actually about that, but what we aren't seeing is that this is being picked up by the leaders in the system. They're under massive pressure, all sorts of demands on should do, actually. And so I think we want to see that. I think I need to see that change, really.
Brilliant. Thank you, Shaun, and apologies for any technological glitches there that people might have experienced. I think you both, Joanne and Shaun, highlight some really important issues, and I was really struck by the sense that the system is breaking people. I thought it was a really powerful kind of phrase, and the whole idea of compounded harm. And then Shaun recently just picked up there the importance of leadership and leadership as setting the tone. And one of our questions, I'm not going to give full names, but from Kate, asks, how does compassionate leadership fit with this? So I wonder if I could invite panelists to reflect upon the role of which leaders could help, through their own compassionate approach, through fostering a compassionate culture, actually provide the kind of the framework or the sense in which restorative approaches could be applied more routinely in the services. And I'm quite happy for anyone to pick this up.
Shall I go first? I'm sure others will have a view on it. What I hope I was able to get through in my presentation, obviously 15 minutes isn't a long time to talk about something so nuanced. But I think, we talk a lot about culture and we talk a lot about people's mindsets, and I think that's absolutely right. And I think the mindset and the role modelling by senior people in organisations, and indeed from policymakers downwards, is really, really important in this if we're going to see a shift towards only focusing on organisational learning as an outcome. But I think also what I hope to have demonstrated is that it's not good enough just to have a shift in mindset. We do need to look at our infrastructure. We need to look at the resources that are available to do this work. There are a lot of questions around, for example, the model for undertaking this kind of relational work. There are various different models that organisations might use, but they need to be resourced. People need to be trained and have the competence. And really importantly, what we don't want to do is increase compounded harm in investigators. Being a full-time investigator or doing this kind of work is really emotionally burdensome. And so I think we need to proceed optimistically, but with caution, and it needs to be a process of ongoing inquiry from senior leaders downwards about how to, as Jo has in New Zealand, so I'd be really keen to hear from her too on this, think about at a system level what this might look like. What are the barriers at a system level to doing this? Do we go forward with thinking about perhaps no fault compensation as being a potential route to support some of this stuff as well? So I think there are lots of things that we need to think about, and we, as I say, are only really starting to take baby steps in this country, I think, towards this approach.
Thank you, Jane. And I think that nicely it fits with a question from Mary from Cambridge. I'm not sure who that is, but Mary would like to know what would need to happen to address Shaun's call for the restorative approach to be picked up by the system. And maybe Jo might want to reflect upon this from her experiences in New Zealand.
Thanks for the offer there, Justin. And it just so happens that next week we are bringing together people from across the health sector. We've just done about 18 months of restorative design work through the collaborative, looking at what is a restorative system and what are the enablers and barriers within our context here in Aotearoa, New Zealand. And that work has been led by the collaborative, which has, when we think about leadership, it has leaders from across the system. So restorative principles promote equity. So within that, we have harmed patients and families, we have clinicians, we have regulators, very senior regulators and decision makers from across the agencies that respond to harm. And one of the reasons why we wanted to do that was that we wanted multiple perspectives in the design of what a restorative system would look like and what the conditions might be that would create success. So that we're not designing something in isolation. And I think one of the key points that we want to make next week when we come together to share our recommendations is that we want to see a single point of entry for harmed patients and families and staff who are involved in a death or serious harm that is trauma informed and that coordinates responses. Now, this probably sounds like a bit of a pie in the sky idea, but there's a lot of support here because we've spent a couple of years bringing people together to look at that. So when we think about a suicide, for example, it's not just the investigation process that people have to go through in terms of a learning review or a safety investigation. There's also the coronial process. That can be really quite traumatizing for all the people involved, the staff, as well as the patients, the organisation. And then there's the legal processes around trying to have your voice heard or trying to access compensation. One thing we do have here in New Zealand is no fault, no blame. So you can't sue a health provider, but you do have access to compensation, which is funded by the taxpayer. So there are some conditions that I think enable this kind of work. Certainly in the US, they have apology legislation as well, so people can freely take responsibility for the conditions that led to the harm and the actions for prevention and repair, and compensate financially the family involved as well. So some of the systems principles, it's about looking at all these different interactions and then trying to co-design together, what does good look like? What do we actually want for a meaningful response?
Thank you, Jo. And I think that nicely touched upon some of the other questions that we've had about how kind of wider legislation and statutory issues can help to support and facilitate a restorative approach. One of the things I'd like us to pick up on is Joanne's point about how kind of the restorative approaches doesn't necessarily sit easily with the more investigative approach, and that's something that Jo also described. And I suppose one of the questions I have is do we need to think about these as parallel approaches to how we deal with patient safety events, or can we look to integrate them some way? For example, with the work that Jane is working on with the restorative learning approach. Joanne, would you like to kind of say a little bit more about your views about whether these might be separate or integrated approaches?
I think the restorative learning process that Jane's team have supported is one part of the restorative response to the harm that has occurred. And so, if from a patient perspective, the needs that you have first and foremost is to understand what it is that has happened to you. So one, you need to understand, what were the event, but two, what was the impact of the event on the patient, and how has this led to this situation that you're in. So for the patient and family, the sort of dominant need, I guess, from the learning reviews is not so much the system learning, but my own understanding and sense making of what has happened to me. And I think that just recognizing that this learning response is one small part, which is about understanding your diagnosis, if you like. But then the next part is, right, what next? Well, what are you going to do to help me heal from this then? Which is back to that sense of you're looking for this healing, caring response from the healthcare system to this injury that you have. And that injury is wide-ranging, as Jo explained, emotional, psychological, relational injuries that need attending to in order to put them right and for you to be able to move forward from the event. And I think that is so much bigger than this learning review. And I think that the system is confused that the response to harm is to learn. And because it is in that space, and because I think patients and families are fed in a little bit with exactly what you articulated earlier, which is Shaun said, we just don't want it to happen to anyone else. No, we don't. That's right. But we also really want the fact that it's happened to us to be responded to in a healing way. And I think that's the bit that's missing. So how can I put it? If my child passed away, so if it were to happen today, the system might come to me and say, Joanne, let us explain what happened to create that incident, and we want you to help us get to that explanation. And then when we've got it, what we'll do is we'll use that for system learning. That's gold standard. Hope you're happy with that. Well, nobody, and if they stopped and thought about it in that situation, would be healed by system learning. It's all the other stuff that goes around recognizing what this has meant for us and what we need to be able to recover from this going forward and restore our trust and relationship in the organisation. Does that make sense?
Thank you, Joanne. That's brilliant. And what I might do now is then invite Jane to reflect on how, and I'm thinking here about her work working with policymakers and the like. How do you try and promote or advocate for a restorative approach in a way that doesn't get captured by the systems, and the way that doesn't become too tokenistic, in the sense that it's just another thing that we have to go through. Do you have any thoughts about that, Jane?
I do. And, you know, I think Joe's absolutely right. And we've come to the conclusion, I think, that, you know, well, when we started our work, we had to start from where we are. You know, we're in a system that does these investigations as they are, and we were trying to improve a very specific aspect of it. It's become a lot more than we originally imagined. But I do think through all of the conversations we've had with people like Joe, that we realised that actually there is an ongoing duty of care that cannot be captured as part of an investigation process. And you've so beautifully said that, Joe. That's absolutely right. This is what people are saying to us. Of course, we don't want it to happen to other people, but to be honest, you know, people are explicitly saying, but my need is to know what happened and to understand and to close it off and make sense of it. And that has to be part of an ongoing duty of care, and that is very difficult to accommodate within current investigatory systems. I don't have the answer. I know that policymakers, and I've worked with them very closely in the past 2 years, I know that it's very well intentioned, and I know that they are trying to move a very clunky system forward by very small baby steps. And I think the PSF will represent a good change, that opening up with a variety of learning responses and also thinking about improved engagement and involvement. Will it become tokenistic? I hope not. Will it potentially reduce compounded harm in investigations? Possibly. And you know, and that's a big thing, because that's a key starting point, isn't it? And I think that the NHS as a body need to really grapple with this and think more broadly about what is the ongoing duty of care to people and their families who have been harmed, and think about how that's actually going to be provided, because that is a different thing.
Thank you, Jane. I'm very aware that the time is getting the better of us. And what I'd like to do is ask Shaun now to think about how, in your role as, you know, as a journalist, as often, you know, at the forefront of communicating with the wider public, what do you see as the kind of the best ways or the pitfalls of how we communicate and put forward and advocate for a restorative approach in the wake of safety harms, when often people are still thinking, wanting to know what happened, who's responsible, who can we blame? How can we try and shift the public dialogue around there?
Well, I think a really good example of good communication around all of this was Donna Ockenden's review into Shrewsbury and Telford. I think she did a very good job of communicating and balancing the two pressures, and actually just reflecting on what Joanne said about looking after patients. You know, Donna Ockenden actually provided mental health support to the patients and families who were involved in her review. And actually, I've seen other reviews where that was actively resisted by the NHS and refused by the NHS and made worse. So, you know, in many cases, we don't consider these aspects. So I think Donna really hit the nail on the head in how to balance those things and got the two tensions quite right, I think. And we saw the response from that, both from the system and from the families. Everybody kind of supported her final report.
Thank you, Shaun. And time has now got the better of us, so I'd like to thank all of our panellists and our speakers. It's been a brilliant start to the day. I'm going to hand back to Vivian now and enjoy the rest of your day, everybody. Thank you ever so much. Bye-bye.